Am I audible? Am I audible?
Yes, hello.
Yes, sir.
Yeah.
Good morning, sir.
Good morning.
Sir. This is from Jipmer, sir. Thanks a lot for accepting our invitation and gracing this presentation, sir.
Thank you. My pleasure. Thank you,
Yes, sir.
Jipmer team, you and Dr. Pooja. All
Yes, sir.
postgraduate students are attending, I think.
Yes, sir. I think AIMS Bhubaneswar students are also attending, sir.
Okay.
Yes, sir. So, sir, can we have the audio and video check? I think audio is fine. Can you share your screen, sir?
Yeah.
Yes, sir. You are visible, sir.
Okay. Now I have to share the slides. Just guide me how to share. No.
Sir, if we see in the Zoom screen, share screen, and then
is coming there.
not yet, sir.
Okay.
ஒரு பேப்பர் மட்டும் பேப்பர் பேஜ்
just for 1 minute.
Yes, sir. Yes, sir. The slides are visible, sir.
Hello.
Yes, sir. The slides are visible, sir.
Okay.
So, can we start the presentation, sir?
Yeah.
Oh, thank you, sir.
So, good morning, everybody who are on this virtual platform. This is Sunday morning. Thank you, the team from Jipmer who invited me. Actually, this is a rare opportunity to talk about esophageal cancer. We come across with this type of tumor very less. It's not a regular disease to plan. So like in 1-2 months, we get to see 1 or 2 patients like that. So I hope all of you will follow me so that we'll have an idea about this cancer, how to manage and how to treat, how to delineate. So the topic is to target delineation for preoperative or radical radiotherapy treatment. Radiotherapy for esophageal cancer can be definitive, can be preoperative, can be postoperative, can be palliative, or it's brachytherapy. Definitive radiotherapy is given, just I have mentioned here, like 50 to 66 gray, or preoperative like from 41 to 50 gray. Post-operative practice is very rare because you have to include a big volume, including the anastomotic site, whether it is in the thorax or in the abdomen, if you like or not. So you have to include it and you land up with more toxicity. So post-operative radiotherapy is rarely practiced, but sometimes we have to do that. Palliative is for palliation and brachytherapy in some centers. Diagnostic workup is routine only. Take clinical history, complete blood count, chemistry profile, but endoscopic biopsy is important. As you know, patient always will tell about dysphagia. Dysphagia comes only when the lumen is 13 millimeters, which is around 70% blockage is there. To start with, they will have dysphagia to solid, and it's progressive in nature. Later on, it will be for solid and lipid also. So this is commonest symptoms. Also, you will have loss of body weight. So endoscopy will give good information about mucosa, about the obstruction and the extension of the disease, and you have to take a biopsy out of that. So biopsy will confirm the diagnosis. CT scan, thorax, abdomen, pelvis are done to do staging workup. PET CT scan is done, I'll tell later on, and bronchoscopy to see the extension to the trachea bronchus. Sometimes patient will tell, when we take any liquid or food, I do have a cough, means there must be some fistula there inside. So you have to go for bronchoscopy to see the mucosa is involved or not. Nutritional assessment is very important before starting any therapy, whether surgery, radiotherapy, or chemotherapy, whatever. So we have to establish whether feeding can be done from jejunum, from the stomach directly, like that, or in some case to put Ryle's tube like that. So these are all diagnostic part. But we have to have a basic knowledge about decision making of a cancer treatment. You just can go to NCCN guideline or collect the information from various clinical trials. NCCN 2022, if you can see here, when your diagnosis is confirmed, your staging workup is confirmed as a T1 or T2 disease very early. T2 means up to submucosa, disease is confined. T2N0 means stage 1. Just think about stage 1, and the tumor size is say, less than 3 centimeter, then you can go for directly esophagectomy. Just I want to tell you that the treatment up before 20 years of time, the treatment was just surgery or radiotherapy, and there is evolution of the surgery all the time. So esophagectomy is one of them. There are different approaches how to do this, but we all agree that surgery has a limitation, and this surgery should be done in T1 stage or T2 stage with tumor less than 3 centimeter esophagectomy, or even in early stage with poor prognostic factors like biopsy we have done, poorly differentiated tumor, lymphovascular invasion is there, or tumor is more than 3 centimeter, then you can directly go for multimodal therapy, which can be preoperative chemoradiation, can be just chemotherapy followed by surgery, or sometimes surgery is done, then postoperative radiotherapy. But to remind you, when it is cervical esophagus, usually surgery is forbidden. You go for definitive chemoradiotherapy. Advanced stage T4B, T4A means you have diaphragm, pericardium. These are the structures, all coverings, or azygous vein. If they are infiltrated T4A, still you can go for definitive chemoradiation or surgery. But for T4B, when large vessels are involved, aorta, trachea, airway involvement is there, then you can go for just radiochemotherapy or sometimes palliative, or sometimes you see there is impending perforation or anything, you can go by chemotherapy fast. Suppose the patient has not received anything preoperative and surgery is done, they come to you, R0 resection is done, then you can just do surveillance, or there is microscopic positive disease, then you can go for chemoradiation. For R2 also, you can go for chemoradiation or palliative management. If the patient has already received preoperative therapy like chemotherapy, radiotherapy, or chemoradiotherapy together, then You see whether postoperatively pathological histopathological report shows YPT0 means pathological CR is there. You can just do surveillance. If the histopath report shows that there is residual disease, it is completely removed, but the disease is still there, then you can go for nivolumab immunotherapy as a maintenance therapy. And if margin is positive, you can still wait. When progression is there, then you can start chemoradiation, other approach or palliation. In case of adenocarcinoma, the things I told about is commercial carcinoma. In case of adenocarcinoma, there is no much change. Again, T1, T2, you go for esophagectomy. For T2 N0 cases, you can go for preoperative chemoradiation, preoperative or definitive chemoradiation, or perioperative chemotherapy. Lower esophagus, G junctions, you can go for chemotherapy alone. So these are the background. Actually, this tumor in 90s, when like we were in senior resident first year maybe, that time RTOG 8501 came. Before that, surgery was there, and few things we used to remember. CA esophagus, what is the 2-year survival rate? 20%. What is the 5-year survival rate? 5%. Means if you do surgery, still it is not working. If you do radiotherapy, still it is not working. Even if radical surgery, big development, then the surgical outcome you can see, it will be like T1 lesion. Some series they shows that 5-year survival could be 70%. It is high, but still they believe stage 1, 70%, you have to do something. Stage 2 onwards, it drops to 30 to 40% if you do good surgery. So surgeons also accept that you have to add something. So this Cooper et al., they published their clinical trial in RTOG 8501. That time radiotherapy was there, we can add something to radiation. So they gave chemotherapy to the radiotherapy. Initial phase of this therapy was that they included full esophagus. We also used to add full of the esophagus in our treatment volume. Then it changed with a margin of 5 centimeter above and below the tumor. So this Cooper et al., they proved first time that if you give radiotherapy and chemotherapy, the 5-year survival is improved up to 26% compared to 0% if you give radiotherapy. So he proved that this radiotherapy alone is useless. If you give 0% is the outcome. So the first time they decided we have to always give a combination therapy. Then came intergroup 0, 1, 2, 3, Minsky et al. They published their findings in 2002, and they proved that if you do dose escalation, you increase the dose up to 64.8 gray versus 50.4 gray, there is no benefit. So now we come to know that combination therapy is required, and we also come to know that 50.4 gray is adequate probably. Then came German POET trial. German POET trial came in 2005 by Michael Saal. They gave neoadjuvant chemotherapy followed by surgery versus neoadjuvant chemotherapy followed by chemoradiotherapy, then surgery. And they found that the pathological shear improved in favor of chemotherapy and radiotherapy. So this chemoradiation is little bit better than chemotherapy alone. We can come to a conclusion in this. Then came CalGB 9781 Tepper et al. They published that chemoradiotherapy dose was 50.4 gray in 28 fractions followed by surgery is better than doing surgery alone. This number of patients are less because the recruitment was stopped due to poor patient recruitment. But in whatever 50 plus patients they had, they found that 5 years overall survival is improved to 40% compared to 15%, and pathological CR was 40% if you add chemotherapy, radiotherapy before doing surgery. Then in 2015, the landmark trial came, cross trial, which is all of us, like all residents from radiotherapy should know that when again at all they published this, of their 366 patients, You have to remember this. 366 patients, 75% were adenocarcinoma, 23% were squamous cell carcinoma, T2 to T3 lesions or node positive lesions. What they did, they gave preoperative chemoradiotherapy to a dose of 41.4 gray and carbopactlic chemotherapy. All were weekly, carboplatin area under CAR2 and paclitaxel 50 milligram per meter square. Weekly given, then surgery was done around 4 to 6 weeks time. Or surgery alone. If you compare, the endpoint was overall survival here. You can see 5-year OS improvement from 33% to 47%. And the important point is that R0 resection improved from 70 to 90%. 90% R0 resection. And pathological shear was about 30%. We all ask this question in MD exam. So everybody should know this cross trial. The 30 days mortality rate was 3%. Radiotherapy planning, little different, which I asked that in this case, there was no CTV. If GTV is there, then directly you give margin to create PTV. The margin given was 4 centimeter superiorly and inferiorly and 1.5 centimeter radially. 3 centimeter distal margin in case of stomach was given. The interesting point was that the recurrence rate beyond margin was very less. And the marginal failure was only 2%, which means if you give 4% margin or 3% margin, it is adequate. The criticism to this trial was that the pathologies were different, 75% adeno, 23% squamous cell carcinoma, and the surgeries were different types of surgery. That these two things were but the design of the study was very good. This study came from Netherlands. Everybody started to follow. This is the graph, Kaplan-Meier graph, which shows that the survival is improved in favor of chemoradiotherapy versus surgery alone. And this improvement is also seen in all categories. Squamous cell carcinoma, adenocarcinoma, the improvement is also there. Then came Alliance trial. The purpose of the trial, they use PET CT scan. And they saw that if there is a response, the response to chemotherapy was FOLFOX, and another group was that carbo and paclitaxel. Two types of chemotherapy they added, and there was a crossover. If one is not responding, go to other. So after that, you see that when there are two groups, people who did not respond to carbopactli were taken to FOLFOX group before doing surgery, and they found that the response was better. Another one, in the FOLFOX group, if the PET response was very good, then the 5-year survival was very high. It's more than 50%, which shows that little idea about carbopactli versus FOLFOX. Probably FOLFOX has a better response in some cases. Another trial is ARTDECO. ARTDECO trial, what they did, the primary endpoint was local progression-free survival. What they wanted to see effect of radiotherapy dose escalation to primary tumor on local tumor control for a definitive chemoradiotherapy group. In this case, there was no surgery, chemoradiotherapy was done. The dose was like one group is 50.4, another group is 61.6. And they found that there is no definitive chemo improvement in case of doing high dose 61.6 grade to the primary tumor. So this also consolidates our idea of dose escalation is not working. ESPRESSO is a trial to see the esophagectomy. Suppose patient has good clinical response. You gave radiotherapy, chemotherapy, then you evaluated before surgery, clinically complete response is there. Whether you will go for surgery or not, this trial told that the local control is better, but there is no survival advantage. So close observation is one option compared to salvage surgery even after complete response. So this will open up more trial in future and we'll come to know. But our role is to, then we have to decide. Suppose patient has come, we have this background knowledge and patient needs radiotherapy either for preoperative or for radical chemoradiation. So what we should know before going for therapy also. It is more or less anatomical knowledge is required before going for treatment. That is what I will highlight here. Clinical anatomy for esophagus. So it is just few things I will tell. It's the length is 25 centimeter. Endoscopy is done. You measure the tumor from incisor to down to 40 centimeter. 40 centimeter is G junction, and this starts at 25 cricopharyngeus junction, which is nearly 15 centimeter in length. So this esophagus is divided into cervical and thoracic broadly. The thoracic is again subdivided into upper thoracic, mid thoracic, and lower thoracic. Esophagus has different anatomically because they don't have serosa. Serosa is not there. Adventitia is there. When adventitia is involved, we call it T3. But they have very high lymphatic system. Submucosal lymphatic system is there. These lymphatics will drain after passing through certain distance. As high as they will go for 8 centimeter, 10 centimeter, then they will penetrate transmurally, again reach the adventitia. So they are typical. That is why we see skip lesions. And initially there was whole esophageal radiotherapy was there. So because of lack of serosa, again this tumor will penetrate quickly, transversely. So this is the difference is there. How to divide radiologically? Endoscopist will give you information, cervical, upper thoracic, middle or lower. This anatomical knowledge is there. Another way to know this is there. What I feel is we should know. The right side, if you see this blue color, is called azygous vein. Azygous vein is why it is called azygous. Zygous means paired. It is only one, and it's there in right side on. So this is called azygous vein. It is in right side. You should know this azygous vein will go to drain superior vena cava. So we are used to see axial cut of CT scan, right? This axial cut this comes from our CT simulator. I'll tell you later on. So in this cut, you can see here the arrow mark. The arrow mark is showing is azygous vein in this cut. So up to azygous vein, up is the 25 centimeter. This is the lower border of the azygous vein. So mid thoracic esophagus will be up to this level, right? So this 25 centimeter we can find out in axial cut here, right? But sometimes we are confused with arch of aorta. You can see this right side pictures. This is arch of the aorta, but this is superior vena cava. This is not draining to superior vena cava. So you can know that this is not azygous vein. Again, here you can see right brachiocephalic vein, right and left. Brachiocephalic vein is always anterior. It is not azygous vein. So this is the azygous vein. This azygous vein we should know. This will give us roughly where we are. This mid-thoracic esophagus is here or not. Lower border of pulmonary vein corresponds 30 centimeter to any axial cuts. This cut we can recognize with a heart, right ventricle, right atrium, left ventricle, then pulmonary vein. This pulmonary vein is there. So this pulmonary vein will tell you the end of 30 centimeter. Below this is lower esophagus. This is one more thing anatomically we should know. Any tumor near to this gastroesophageal junction is called gastroesophageal cancer. They are little different. This can be squamous cell carcinoma, this can be adenocarcinoma, but you have to see where is the epitome of the tumor. They are classified as CWAT types 1, 2, and 3. Just junction is there. From junction above 1 centimeter to 5 centimeter is called type 1. Below 2 centimeter from gastroesophageal junction to 5 centimeter, 2 to 5 below is called type 3. And the in between 1 to 2, they are called type 2. This type 1 and 2 is called treated like esophageal cancer, but some also they treat like stomach cancer for type 2. Type 3 is always treated like stomach cancer. You can give like flot neoadjuvant chemotherapy, then surgery like that. But one more thing you should know that you have to take a history. If there is H, suppose type 2 is there, but H. pylori is positive, then you go for stomach like treatment. Suppose there is Barrett's esophagitis, reflux is there, but it is type 2, then treat like esophageal cancer. So this we should know, because this junctional tumor we get, and we sometimes do mistake also. Later on, I come to know that no, maybe celiac node was included, should have been included, because we treated like esophageal tumor. So you have to be very careful. When you are confused, you take the help of PET scan. PET scan also, they have classification for this CUAT type 1, 2, 3. You can see here this very high uptake is there. You see the epitome of the tumor here. This is CUAT type 1. This is CUAT type 2. And type 3, you can see G junction going to cardia of the stomach. So these are the area type 1, 2, 3 we should know. PET scan has a advantage of telling you. Sometimes CT scan will tell you this is a lymph node, but you are not sure. But see this side, this PET scan is high uptake is there. This is a lymph node, right? So PET scan for esophageal planning is very useful. Then comes lymphatic, knowledge about lymphatics. The esophageal lymphatics network is located within the submucocyto. The lymph can travel entire length of the esophagus before draining to lymph nodes. The lymphatics of esophagus usually follows following arteries: inferior thyroid artery, bronchial artery, esophageal artery, and left gastric or celiac axis. Here in this picture, you can see the supraclav group of lymph nodes. It's mostly seen, say 10 to 20% of the cases of upper thoracic tumor. Middle thoracic tumor, you can see supraclav only 4%, not much. But you can see mediastinal group of lymph nodes are very high, 32%. And in case of G junction tumor or lower thoracic tumor, you can see the lymph nodes below in the abdomen is 30% and only 1 to 2% in supraclav area. So they follow a particular pattern also according to the location of the tumor. Should we include all these lymph nodes or not? Then this knowledge will come from our surgical series knowledge. Perry et al. They published in Annals of Surgery in 2008, where they told that lymph node dissection is the independent predictor of survival. The optimal number of lymph node dissection is more than equal to 23. So lymph nodes should be treated. The answer is that. There is a pattern of failure I found in one literature. You can see in this picture, they gave actually high dose. So first there is a volume say 50 gray, then 54 gray PTV. You can see bigger field, and there is 66 gray area which is inside the bigger field, and they evaluated the pattern of failures. Failure can be local failure, failure can be regional failure. You can see the local failure is inside the high dose area, PTV 66. And the regional failure you can see in the supraclav area. So this also tells that high dose is not much of important. This lymphatic area, regional area should be included. Otherwise, later on they will have recurrence. This is another way to see that cervical esophagus includes supraclav and upper mediastinal group of lymph nodes, proximal third of supraclav and upper paraesophageal group, middle third of the esophagus, they drain to paraesophageal, distal third or G junction tumors, they drain to esophageal, lesser curvature of the stomach and celiac axis. So these group of lymph nodes are included. Now comes supraclav, cervical group of esophageal tumor. You have to control from cricoid to sternal head basically. So this is like head and neck cancer. you know, supraclav area. The upper part is cricoid cartilage. The caudal end will be the head of the clavicle. Anteriorly, there will be sternocleidomastoid. Posteriorly, scalene muscles. Sometimes I will tell you that sometimes this tumor, cervical tumor, is extending to hypopharynx, to the larynx. That time, the dose we are giving to 66 gray, extrapolating from head and neck cancer. The dose is not 41, not 50, not 54. It is 66 gray. And the contouring, like head and neck, here you can see medially there is a trachea, posteriorly scalene muscles, anteriorly sternocleidomastoid, and brachiocephalic vein, or you can just see the lateral part of the sternocleidomastoid. This is the end. So these are the area is for supraclavicular or upper lower neck lymph nodes. This is included in cervical esophagus or upper thoracic esophagus. So this is a contouring one. Now, CT-based definition of thoracic lymph nodes. I have not come yet for simulation or anything. These are the basic knowledge we should know before taking up any esophageal cancer patient. CT-based definition of thoracic lymph node. There is a station from 1 to 11. Different, I will just quickly tell you how they are seen. So this picture you can see here. They have mentioned like 1, 2, 3, 4, like this, everything is there. So 1 is upper mediastinal. You can see it. This is brachiocephalic, this blue one. It is crossing, the brachiocephalic is ascending towards left. And it is crossing the trachea. So in front of the trachea, where the brachiocephalic is ascending, a horizontal line you can draw. This horizontal line. Above this is called superior mediastinum. This also is included in supraclavicular group of lymph node. So 1, you can see left side 1 is little lower, right side 1 is little up. Then comes 2. 2 is upper thoracic. Upper thoracic. You can again see this is lower border of this brachiocephalic vein, and above this level station 1 group of lymph node. In between that area is right side station 2 upper thoracic. Left side the horizontal line is passing through arch of the aorta. So 2L is at the edge of the trachea. Left side, if you can see. Right side it is little upper. Again 4R. 4R is peritracheal and esophageal or mediastinal, you can say. They are in this group. The lower border of this is at the level of carina. So a horizontal line you can see, arch of the aorta, brachiocephalic vein, and a line above which is passing through trachea and right bronchus junction. So these are the areas. So these are the station. You should know also 7, which is subcarina, and this 11 to 14 is hilar group of lymph node. 6 is para-aortic, peri-aortic group of lymph node. So very easy to remember like this. These are the stations. So 1 minute. Supraclavicular and upper paratracheal. These are the groups. Supraclavicular, upper paratracheal. As I told, upper mediastinal you can tell it, or upper paratracheal group of lymph node you can tell it. This is again important. This is called prevascular group of lymph node. Prevertebral group of lymph node. 3. Station 3 mediastinal lymph node is called prevertebral. Anteriorly is called prevascular or pre-aortic, you can say. Aorta is there, prevascular. This group of lymph node is always included for upper cervical and upper thoracic group of lymph node. 4 I told paratracheal group of lymph node. 6 is para-aortic. This same para-aortic. So these are the station of lymph node, mediastinal lymph node we should know. But we are used to again axial cuts which come from our CT simulator. These are all radiological pictures taken from the textbook. You can see here one upper mediastinal or even supraclav, you can call it. P is prevertebral group of lymph node. Whole this area needs to be included. 3P prevertebral and this sternal notch area. 1. This is prevascular, this anterior part. 3A paratracheal 2 and 3P is prevertebral. These are the two. So upper thoracic and cervical area, you will include this type of. This is the contouring showing how you include. This yellow line you can see is including everything. There is no harm. Sometimes I've seen contouring like this, leaving some area, but you include all these three areas, all this. So this is again showing this prevascular group of lymph node, prevertebral group of lymph nodes. Hilar, this paratracheal, esophagus is here. So these are the regional lymph nodes. Subcarinal group of lymph nodes, 7. Paraesophageal, paravertebral group of lymph nodes. So these are the lymph nodes. So this mediastinal group of lymph nodes, roughly you know who are they. Now for abdominal, suppose G junction tumor, you are treating like say stomach or lower part of the thoracic esophagus, you have to include because the drainage is going down to celiac group of lymph nodes. So in this cut, you can see this is taken from Matzinger et al. And you can see paraesophageal lymph node, which is 110, which is in this area. Esophagus is there. There is a green line, which is covering esophagus and the regional lymph nodes. You can, IVC is there, heart is there, and this whole area, empty area looking black is a soft tissue area. You include that, including esophagus and this triangular area. This whole area is paraesophageal lymph nodes. One is triple one is a supradiaphragmatic lymph nodes. Sometimes if the tumor is here, suppose big lymph node is there, then you can go little lateral to include this group of lymph nodes. But very rarely we include to increase the dose to the heart will go. Another one is, again, this is esophageal hiatus of the diaphragm area. You can see this lymph node area, esophagus plus periesophageal lymph nodes. This is another one is short gastric vessels. This liver is there, right and left, and this heart is there. Then this is short gastric. The stomach is coming down, just starting. Again, this is the area which is lesser curvature of the stomach. This lesser curvature stomach is this is gastroepiploic, purple color. Blue color is lesser gastric artery lymph nodes. Similarly, other here you can see splenic hilar group of lymph nodes. This is celiac lymph nodes. This 9. The celiac artery is there. A is abdominal aorta. 9 is celiac artery. It's comma like always very easy. Then go down, you will get mesenteric artery. Another like this only. By that time you get kidney both sides. You will see here. First one will come celiac. So these are the regional abdominal lymph nodes. So with this background, how we treat the patient. As you know, when you prepare the patient for radiotherapy, either radical or preoperative, so you have to take consent, check the biopsy, and explain everything regarding the toxicity, then take to simulated room. The patient is advised to come with empty stomach at least for 3 to 4 hours. It is more so when it is G junction tumor. Otherwise, in the upper part, you can have 2 hours fasting is adequate. Patient is taken in supine positions, arms are kept over the head. Why over the head? Because in different angle, you can take the beam. Immobilization device, as per the departmental policy, you can use thermoplastic cast, backlog, body fix, alpha cradle. Intravenous contrast is helpful to delineate nodal basins. And the slice thickness is, we are taking like 3 mm, sometimes 5 mm. You can give oral contrast also to delineate GI structures like stomach. You can give oral contrast also. If you have facility for 4DCT, it is very helpful to do the motion management. If, as you know, this is a structure, abdominal structure like G junction tumor will have more distortion during therapy. They move as more as 3 to 5 centimeters. So if you have a motion management system in your department, you can utilize 4DCT. That will help you to reduce the margin. And sometimes during therapy, patient reduces body weight due to poor nutrition. Then you have to do replanning. So this is how a CT simulator is there, wide bore CT simulator. Patient is taken up in the flat couch. Axial cards are taken in gantry 0 positions. All these images are taken and sent to planning system. I think all of you know this. Before going further, I will just take you to the history. During our time, we used to plan like this conventional method, simulation. You can have just surface marking, then go for X-ray, or X-ray simulator were there. Then came simulator with CT facility. Only one cut you can take, called simulator CT. Then came CT simulator. So this is one plan. You can see barium is shallow X-ray is done. There is a narrowing somewhere. We think this is the primary tumor. From the edge of the mucosa, this side at least 2 to 3 centimeter laterally it is taken, and from tumor to above 5 centimeter, below 5 centimeter. Very nice geometrically it is taken. So patient is supine positions, arms over the head, neck nodes, if at all palpable, you put it where. Then ask the patient to swallow the barium, because otherwise it will pass through stomach, you will miss. During the X-ray time only patient will swallow and you take the pictures. They are treated like APPA up to 40 gray. Then you do spine sparing. If it is upper cervical esophagus, you can see here, upper border is cricothyroid junction, lower border is below carina. You take the margin accordingly. And again, mediastinum, you have open up, keeping 2 to 3 centimeter margin laterally. And see that clavicle, below clavicle is 1 centimeter below, 1 centimeter below. This shaded line is a area to shield the lungs. This is done by 5 HBL lead. It is customized in mold room. Then during treatment, this area is shielded. So the open up area is this one. T-separate area is treated for cervical esophagus, upper esophagus, like this. So these are the, after 40 gray, then you need to spare, because the spine can tolerate up to 45 gray. So from 44 itself, you can spare. In this situation, you put the patient in prone position, because the esophagus will move away at least 1.5 centimeter from the spinal cord. So in prone position, you direct the beam by 3 oblique beams. 1, 2 posterior oblique, one is direct posterior or direct anterior as per the planning and situation of the location of the tumor, curvature of the patient, like that. So this is traditionally radiotherapy planning. In case of lower esophagus, little different. This becomes L-shaped field for lower 1/3 esophagus, because you need to include celiac group of lymph nodes. Again, here 40 gray you give by APPA in supine positions, 2 posterior oblique and 1 anterior field, 16 to 20 gray in prone positions to spare the spine. Right? So these are the area historically. Even if you plan this, advantage is you give very homogeneous dose to the tumor. Disadvantage, you treat everything, all normal structures there, nobody will be spared. Traditional RT fields, if you go to Cooper et al., as I told, RTOG 8501, initially they started doing whole of the esophagus, then they reduced to 5 centimeter craniocaudal margin and 2 centimeter transverse. So this is the first authenticated radiotherapy planning came. but still traditional method. Then came CT scan to radiotherapy planning. This is called CT based planning. Sometimes this simulator machine will have also CT scan option. But here in the CT scan, you contour the gross tumor area, which is shown in red here, and healthy esophagus by green. After this, you just open the field like on DRR image. The X-ray is not direct X-ray. This is software has created this X-ray after the CT scan in the planning system. Then on that, you open up the field length and width and shield the critical structure. Here, you are not doing this 5 HPL shield method. No need to go to mold room. You just do MLC fitting here. Multi-leaf collimator is very easy. So within 2 minutes, you put your MLC here, shield everything, then customize. This is called CT-based planning. You can call it 3D planning. You can see this in lower esophagus. The L-shaped plan we gave in conventional radiotherapy. Here in CT-based plan, it's very easy to draw. You draw the stomach, draw the spinal cord, draw esophagus, celiac axis where it is there. You put few structures. Then again you draw MLC and treat also. It improved. But with the advent of IMRT, 3D CRT, proton beam therapy, VMAT, and also tomotherapy, the treatment design is changing. The basic principle is not changing, but treatment delivery is changing. At the same time, the understanding about normal structure, image, we are capturing is far better than before. So a guideline is coming for each site. So far, we have this guideline, which is expert consensus contouring guidelines by Abraham J. et al. More or less, we are following this. So we'll go through this quickly. What they say. This modern target design is GTB to CTB. Any tumor you can see by PET scan, by endoscope, by CT scan, by MRI, even by clinical information. You put all this information to create a gross target volume as per ICRE guideline. So this gross tumor can be lymph node, can be primary, and then create a margin around it to include microscopic disease. You can include at least 3 centimeter cranially and distally and 2 centimeter radially all around. If the lymph node is there, at least 1 centimeter around the lymph node. As you know, for squamous cell carcinoma, for adenocarcinoma, for anywhere, if you have correct diagnostic approach, even 5 mm is adequate to include 80 to 90% of the microscopic disease. That is why for lymph node, you can keep as 1 centimeter for gross tumor. But the esophagus being little different because of submucosal spread, longitudinal spread, and transverse spread, you have little more margin here. So for cervical esophagus, for upper thoracic esophagus, the CTB includes supraclavicular lymph node and upper paraesophageal group of lymph nodes, as I described earlier. Mid-thoracic esophageal cancer will include middle paraesophageal group of lymph nodes, EG. And lower thoracic esophageal cancer, then your CTB should include lower paraesophageal, celiac, and left gastric group of lymph nodes. IMRT is preferable in some cases. It is better for upper esophageal cancer because of all functional structures are there. Dose to the lungs to be reduced. So IMRT. Recently, one article came in JCO 2020, Lean SH et al. Phase 2, I think proton beam therapy. They compared IMRT versus proton beam therapy. The 3-year survival rate was like 50% both sides, IMRT and proton beam therapy, but the toxicity were very less. So newer therapy treatment delivery techniques are coming up, but for wide, like in Indian scenario, most of the centers, they use 3D CRT and IMRT. Proton beam, only one centers we know. So CTV contouring guideline still it's 3 to 4 centimeter proximal edge from the GTV, as I told, 1 centimeter around the tumor, around the lymph node. Margins should be oriented along the esophageal mucosa instead of being geometric expansion. Distally, you can reduce in some cases. Suppose tumor is going to the stomach. Then in that scenario, instead of 4 centimeter, you can just keep it as 2 centimeter. Stomach is different anatomy, different behavior, and the margin, if you extend, you get more toxicity. The stomach mean dose should be around 30 to 45 gray. In different books you will see, but you should keep as less as possible. So lower esophagus, if you are correct where the tumor is, you can reduce the length of the distal part up to 2 centimeters. This is allowed. If the dose is 45 gray, not 50 or 60, then you can think of going up to 4 centimeters. So each case you have to customize how to take that. Here you can see esophagus in this structure, in this descending aorta is there, esophagus, heart, liver, and vertebra. You can see the CTV, which is green, all around the esophagus is modified because the dose to the heart will be more. So you can go up to 5 mm or 1 centimeter as per the situation. Descending aorta is also, you will try to reduce the dose to this aorta. And also vertebra. There is this barrier, anatomical barrier. The tumor will not go there. So you can exclude this vertebral area. So you can see this green CTV is changing. Instead of being 1 to 2 centimeter margin, it is changing to 5 mm, changing to 1 centimeter, and excluding bone. So you have this liberty of customizing this CTV here. Mediastinal group of lymph nodes, superiorly mediastinum. Suppose tumor is located in lower part of the esophagus, then no need to go for mediastinal lymph nodes. But if any tumor is going near to prevascular area, around the arch of the outer area, then you can include that area that time. So even if it's not mandatory, but this is a lymphatics area, very common failure site, prevascular area. So you can treat that. In this slide, you can see celiac lymph node. Celiac lymph node. How you have to contour it? You have aorta. So right side, you see the vertebra. The edge of the vertebra is the right side border. And 1.5 centimeter margin from the left side margin of the aorta. This is lateral border. Posteriorly, bone. Anteriorly, include this celiac vessels and keep at least 1 centimeter margin. So how this celiac group of lymph node is controlled. And exclude kidney if it is very close to it. Exclude other structure like heart or anything. Here you will not get heart. Here kidney, pancreas, and liver you can find. The location of the celiac lymph node is D12. But you should know how to identify the vessels, the branch from the aorta, the celiac vessels. Similarly, splenic hilar nodes. Splenic nodes are never considered to be a regional lymph nodes. But in SIWA type 2 G junction tumor, you can include. You will include only in T3 and T4 G junction tumor. This was published in Red Journal, Mayer et al. So this splenic lymph node is not a mandatory. In certain situation, you can include. Another one is the lymph node is gastroesophageal junction. This is also called paraortic or gastrohepatic ligament. Stomach, liver, gastrohepatic ligament, or lesser curvature of the stomach. You can see your volume is coming here. This is periesophageal group of lymph node, paraortic group of lymph nodes. You in this area, the stomach is there. This is the lesser curvature of the stomach. This one, is lesser curvature group of lymph node. So this yellow line is including this area. So this is also mandatory for lower esophageal tumor. This is some pictures you can see consensus contouring from T3N1 for proximal esophageal cancer. You can see supraclave is included here. Supraclave, then prevascular group of lymph nodes, esophagus. Here the arch of the aorta, you can see they have reduced here, just 5 to 1 centimeter margins, and this area. Here again vessels are excluded, vertebra is excluded. In the heart area, you can exclude this area. So this is proximal group of lymph node. For distal tumor, make sure celiac lymph node is included in D11. Here is the celiac group of lymph node. I always search for this comma separate like tumor here, structure here. Both kidneys are there. So in this area, you include here, then go up. Here you can see this celiac group of lymph node. Then go up, you will find out this lesser curvature. So you include this lesser curvature group of lymph nodes. This spinal hilar lymph node is up to you. When you add, if tumor is more here or T3, T4 tumor, you know there is no chance of doing surgery, then you can go up to say 45 gray here you can include. It's up to the physicians. So this is for distal tumor. You include celiac group of lymph nodes. Between G junction and celiac nodes, paraortic, left gastric, lesser curvature to be included. G junction, how to find out? You trace from above, esophagus is suddenly you will see here. Stomach is coming, this esophagus is there, G junction. So type 2 G junction you can know, type 3 you can know from this, like this. So then your treatment volume will change accordingly. In severe type 2 G junction tumors, splenic hilum and greater curvature nodes can be included at the discretion of the treating physicians. You can see in this structure, left side, lowermost one, you can see splenic hilum is included here. So this is the guideline for the how to treat the lymph nodes for the CTB, GTB, and PTB as per the departmental policy. Your movement and everything, you have to have your own PTB guideline. Roughly, we take as 5 mm to create PTB. Few slides are here. This green is PTB, blue is CTB, red will be GTB. You can see how in airway, in arch of the aorta, and in the vertebra area, it is all modified. Even PTB, you can see little modified in vertebral area. Somewhere you can modify it, and in the lungs area it is modified. Other area they have not touched. So little modification is acceptable, and these are a few how it looks like in heart area also, and in coronal and sagittal section you can see this is the volume it will look. This green is PTB, this blue is CTB, and this is the gross tumor. Sometimes you measure here what is the distance from here to here. CTB, it is at least 3 centimeter. You can make it 4 centimeter if you have doubt. If you have PET CT scan, then it is very good. You can do fusion and find it out. And before going to this planning, first residents should know who are the normal structure to be controlled. Spinal cord, lungs, both sides, both lung. You create right lung, left lung, both lung, heart. You can do left coronary artery, right coronary artery, right ventricles. Then both kidneys, liver, this intestinal bowel loop, and the healthy stomach. These are the structures you should do contouring. Because we have a constant for everything. For lungs, G20, 20 at least, which is very difficult to achieve. We keep it 30% or less. Heart 30, B30 less than 30%, liver mean dose 30, spinal cord 45, kidney mean dose less than 18 gray, stomach mean dose less than 30. These are the regular things you should remember. I'll just go through few cases in our department, what we did. The case one is a 47 years old male with history of tobacco chewing, with complaints of dysphagia and breathing difficulty for 2 months. As I told, dysphagia is most common symptoms, breathing difficulty, I don't know why. So upper GI endoscopy was done. Circumferential growth was seen with ulceration of the mucosa. It is from 20 centimeter from incisor. So it is upper esophageal cancer. Biopsy came out to be moderately differentiated squamous cell carcinoma. PET CT scan was done. The uptake was 2 centimeter thick, with 5.9 centimeter length, SUV 30. The disease was from C7 to D3. So you can call it like upper esophageal tumor. And trachea, loss of fat glands. So you can do staging system. We planned this case like definitive chemoradiotherapy. For this case, we had 54 gray in 30 fraction planning with weekly paclitaxel and carboplatin. You can see here, supraclav group of lymph nodes are included, and perivascular and esophagus regional lymph nodes included. This is the volume, GTV, CTV, and PTV. So this is how the IMRT treatment volume. This is isodose line. Color was it's covering the area you wanted. So this is the treatment plan. This is for upper esophagus and maybe cervical some part. The case 2 is a 52-year-old male, a known smoker, alcoholic, complained with progressive difficulty in swallowing for 4 months and weight loss. Upper GI endoscopy showed circumferential ulcerated lesion with unhealthy mucosa at 26 centimeters from the length of 4 centimeters. Biopsy was done. It was squamous cell carcinoma of the esophagus. CT scan thorax abdomen done as a staging workup, no metastasis. The lesion of 5 centimeter length in mid thoracic esophagus of a maximum thickness 9 mm. So we planned again with we take a decision with a surgical oncologist whether operable or not. Mind here, in Western countries, say in cross trial group patients were all resectable tumors. And after doing neoadjuvant chemoradiotherapy, the resection was 90%. But in our scenario, most of the tumors may be not potentially resectable, maybe not, in doubt. Sometimes, okay, follow the cross trial, nobody will complain. So we take up for neoadjuvant chemoradiotherapy. So this case also we took for 41.4 gray neoadjuvant chemoradiation. This is mid thoracic, so no problem. Periesophageal group of lymph nodes. This heart, lungs area you can see, little is included heart area. So this is the volume, sagittal sections, GTV, then this CTV and PTV. And this is the color was treatment isodose line, which showed good coverage of the tumor. So after this, patient will go for surgery at 4 to 6 weeks time. Case 3 is another 56-year-old female complained of progressive dysphagia to solid for last 4 months. Endoscopy was done. There was stricture with nodular growth starting at 35 centimeters from the inside. Poorly differentiated squamous cell carcinoma, esophagus, CT scan, chest and abdomen is done. There was G junction thickening, length 4 centimeters along the gastric cardia and extend into distal part or lower part of the esophagus. Few subcentimetric lymph nodes. Plan neoadjuvant chemoradiation. Here you can argue, you can give float here, you can give Folfox here, but we gave treated like cross trial 41.4 gray chemoradiation. So this is the volume, GTV, CTV, PTV, and also you can see celiac group of lymph node is included here. This one, comma, and this is the dose. You make sure the dose to the stomach liver, spinal cord, and heart, and also lung should be within permissible limit. This you can find out from the books also. Now it's nowadays available in NCCN guideline, how to do investigation, staging, simulation, even it is there in NCCN guideline. GTB, CTB, PTB, all these things are also there in NCCN guideline. And same here with the normal tissue toxicity, V20, we concentrate on V20 and mean dose. Make sure at least V20 should be less than 30%. They have kept it here V20 less than 20, which is rarely achievable. Spinal cord less than 45. Liver, left kidney, all of you, I hope, know this. So one more thing I want to tell here that, but always each case is different. Just don't follow, because suppose what my thought about this cross trial and all. Suppose patient comes here, say after 41.4 gray, say after 4 weeks or 6 weeks time, you find that now surgery is not possible. Then you think that this 41 gray may be less. You cannot again start giving booster dose or anything. Gap is at least 2 months time. So sometimes we think maybe I could have given 45, 50 like that. So you see the tumor volume exactly, discuss closely with the surgeons, and if you think it's doubtful for surgery, go for 45 gray, then boost to the gross tumor area and go up to 50.4 gray. This is my thought, so that in those cases you don't repent that I could not give adequate dose, because the tumors they present to our clinic are usually like that, very high volume disease is there. So thank you very much. I will be very happy to take all your questions.
Thank you very much, sir, for the crystal clear presentation. Starting from the anatomy up to the planning, sir. Starting from the conventional up to the conformal techniques. It was wonderfully explained, sir. It cleared almost all of your doubts. However, some doubts are there. Shall we proceed with the question session, sir?
Yes, please.
Yeah. Sir, first question actually, in the case of patients who are having tracheoesophageal fistula or loss of fat plane with trachea, respiratory airway, should we go with curative intent or palliative intent or best supportive care, sir, due to the risk of aspiration that can happen after?
So when patient comes with tracheoesophageal fistula, first you have to establish like whether you can prevent this from aspiration basically. So how it is possible? You can put stent. You can ask your GI gastroenterologist to put a stent. This is the best way to prevent this accident. I have seen young patient dying due to aspiration, due to this fistula. And if you add radiotherapy, the fistula, in the book you will see small fistula may heal up, or this radiation can open up and the fistula will become even bigger. So try to avoid radiotherapy. If radiotherapy you are giving, give less dose per fractions, but best way is to go with chemotherapy alone in that type of situation, so that the tumor will shrink, probably fistula will heal up, but the best way is to divert the feed from the stomach. Usually tracheoesophageal area fistula is there, so you do the feeding jejunostomy, avoid at least feeding, or you can put a stent. Stent, make sure it should not migrate, very common. It will migrate also, but this is the only way. And I will suggest to go for chemotherapy first, then evaluate again, then go for chemoradiation. But always make sure that radical and palliative is a case you have to see the outcome of the patient, biology, nodal burden, and then only you take a call. But I will go for radical treatment, even if fistula is there.
Thanks a lot, sir, for the minute points as advised by you, sir. We would go with the case-to-case basis and taking into mind the pros and cons. Sir, the next question will be regarding intraluminal brachytherapy. In which cases should we absolutely avoid going for intraluminal brachytherapy, sir?
Brachytherapy is given, number one, for palliation, given for as a boost. But this brachytherapy is employed for small tumor. So tumor length is say 4 centimeter. Then you take 2 centimeter above, 2 centimeter below. So it becomes 8 centimeter. So brachytherapy up to 8 to 10 centimeter length you can treat. Beyond that, it is seen that toxicity is more. Late sequelae is more, stricture, perforation is there. So brachytherapy is given for small tumor, mucosal tumor. As you know, when you prescribe a dose in the source itself, then the depth of penetration is less, 2 centimeter, 2.5 centimeter. So tumor depth is also key. And so length, particularly small size of tumor, you can go for brachytherapy.
Thank you, sir. So the next question is, in the case of target volume delineation of mediastinal nodes, should we go for targeting all the mediastinal nodes with respect to the GTV, or only the posterior mediastinal nodes should be targeted for coverage in the case of very few posterior mediastinal nodes that are present?
Posterior mediastinal group of lymph nodes are recommended to include. This azygous vein, this draining side area, they are posterior mediastinum group. They drain from the esophagus. In upper esophagus, prevascular group of lymph node, anterior mediastinum is included. Suppose the tumor is located in the lower esophagus, then you avoid upper mediastinal group of lymph nodes. No need. You see mid-thoracic contouring, it's peri-esophageal group of lymph node. You restrict there. So mediastinal group of lymph node is not always taken fully. Sometimes partly it is taken.
Yes, sir. Thanks for enlightening us upon that point, sir. Sir, while giving CTV margin to GTV, the point that we crop the extent that enters into heart or liver up to 5 mm, should we do it for lung also, sir, keeping in mind the respiration also?
Yes.
Or should we crop it fully?
This 5 mm business is with pericardium, stomach, pericardium, liver, and heart. For lungs, you can go up to, suppose your breathing tracking method is there, then you can go up to 1 centimeter for lungs. And you see this both side lung, it's a midline structure. You can very well plan with less toxicity to the lung. So for lung, it is not like 5 mm.
Okay, sir. Thank you, sir. So should we go for a palliative intent when the length of the primary lesion is more than 10 centimeters, sir? Lengthier lesions?
You can see the full length was treated radiotherapy alone, RTOG 8501. They
Yes, sir.
compared, you give radiotherapy, high dose 64 gray versus some chemo and 50 gray. This radiotherapy alone is useless in that trial we came to know. So I am not in favor of giving. Give less dose and chemotherapy outcome is better. Even 30 gray concurrently, if you give some trials, they gave actually. So give 30 gray and concurrent chemotherapy, the outcome will be better. So radiotherapy alone as a palliative also is not a good option.
Okay, sir. Thank you, sir. Sir, in the case of a G junction tumor with histopathology being adenocarcinoma, on what basis will we proceed with in the lines of esophageal cancer or stomach cancer, sir?
Yes. So you see the epitome of the tumor, where actually the bulk of the tumor is located. Suppose it is going towards fundus of the G junction, towards stomach, then you treat like stomach.
Yes, sir.
If it is G junction proper, say 1 centimeter above and 2 centimeter below from the G junction, it is CWA type 2. Then
Yes,
you
sir.
treat like esophagus. Nobody will complain. And type 1 lower esophagus, you treat like esophagus, no problem. Only when you check with H pylori. Even if type 2 H pylori positive, treat like stomach.
Okay,
This
sir.
is what I came to know from a book. So you treat that way. So each
Yes.
case that junctional tumor you have to justify with findings.
Yes, sir. Thanks a lot, sir. Especially the H. pylori point we'll adopt in our practice, sir, along with other points you advise, sir. Sir, in the case of boost dose that we are giving after 45 gray to 50.4 gray, should we go for a smaller target volume, keeping in
Yeah,
mind the tolerance of
GTV with
stomach and bowel? Yes,
GTV
sir.
with 1 centimeter margin around is the boost volume.
Volume.
Very simple.
Okay, sir. Sir, and in the case of disease that is reaching up to the junction of hypopharynx and esophagus, that lower border of cricoid, how much superiorly should we extend the upper border of CTV, sir, keeping in mind the tolerance of larynx and also keeping in mind that we have to go up to 66 gray.
Yes.
So,
So head and neck case like hypopharynx, larynx, we treat up to 70 gray.
yes, sir.
We can treat that. So here it is kept 66. It is just extrapolation from head and neck cancer management. So in that case, these are the case they don't do well. We treated one patient like that also.
Yes, sir.
Patient is okay, but had lots of complication during therapy. It's a lengthy volume, but you hypopharynx will tolerate 66 gray, no problem. Larynx
Yes.
you can keep mean dose 45 gray, that is there. So that is not an issue. So you can give that. Only thing they cannot tolerate this concurrent business, Pacli, Carbo. That time we reduce Pacli, we avoid, give only carboplatin. This both things they will not tolerate for cheap.
Okay, sir. Thanks for your advice, sir. Sir, and while giving margin to the gross lymph node, should we go for 1 centimeter or 1.5 centimeter margin, sir? The CTV margin that we give from the gross lymph node.
1 centimeter is adequate. You have done PET scan, CT scan, everything. 1 centimeter.
Yes, sir. Thank you, sir. Sir, with respect to immobilization, Wacklock versus wing board, any preferences, sir? Any advantages you would advise, sir?
We are using this thermoplastic mask to fix this. Backlog, in my experience, lots of sagging, everything is there. But again, it depends on the therapist also. In some centers I have worked perfectly, they will match, they will do everything. In some centers, it's tough job. So this mask, thorax and abdomen mask, that also is good. But anything which is fitting to your center, your team, they will do it. So finally, during treatment, you have to have portal image, you have to have image verification, then only we can treat correct.
Yes, sir. Thank you, sir. Sir, how to decide on the technique of irradiation? So 3D CRT versus IMRT or VMAT based on the tumor extent or any other factor?
Now we know that IMRT is better than 3D CRT.
Yes, sir.
Suppose lower part G junction area, IMRT is better. Suppose upper part is there, then simple 3D CRT will also achieve. So you have to generate two types of plan, but personally I think IMRT will be superior as of now. But some cases 3D CRT is easy. Suppose your lung dose is coming very high due to irregular tumor, due to extension of the tumor, then you compare with 3D CRT. Because the contribution outside the field is zero actually to the lung. So sometimes we compare both and we take up the better one. So never restrict to a fixed idea that 3D CRT is better, IMRT is better. But IMRT literature is showing IMRT is superior, and proton beam IMRT even superior to IMRT. This is what literature is saying. But even 3D CRT in certain situation is also good enough.
Yes, sir. Thank you, sir. So we'll take into account both the techniques and decide which would be the best. Sir, and in which instances should we give oral contrast during simulation, sir?
Suppose anastomotic site you want to see, post-operative radiotherapy is there. Contrast is very useful. The location of the anastomotic site is difficult with CT scan. And doing endoscopy that time is also difficult. So you did not give preoperative chemoradiation. Patient came with surgery, and the anastomosis is in the thorax or in the abdomen area. So you better locate that with contrast. Sometimes for lower esophageal cancer, G junction, oral contrast is better because you want to delineate whole of the stomach better.
Yes, sir. Thank you, sir. So, what should be the radiation dose for squamous cell carcinoma of cervical esophagus with hypopharyngeal involvement, sir? In neoadjuvant, in radical RT 66 gray, while in neoadjuvant RT, when the surgery is planned, and when in one setting is when neoadjuvant RT followed by surgery is planned, and when the other setting is neoadjuvant RT, where
Got
surgery
it.
might not happen.
So
Yeah.
something around 45 to 50.4. 50.4 gray.
Okay, sir. Okay. So, next question is, sir, for cervical esophagus CT simulation, whether the hand should be up or down, sir?
For all type of esophageal cancer, hand is up.
Up, yes, sir.
Yeah.
Sir, then the next question is, in the case of upper esophagus with a uh, gastric lymph node that is present, or if the primary is in the lower esophagus with a supraclavicular lymph node extent, what should be the contouring? Should we include the esophageal part or just the lymph node?
It
Uh,
means it's a skip metastasis.
skip.
You have located your primary tumor, say lower esophagus. So that is your PTB. You will not go on contouring up to the node area. The node you can contour separate and deal with separately. Supraclav lymph node has come. Lower esophagus you have contoured. Lower periesophageal lymph node you have contoured. You treat that, and supraclav area you give another radical dose. I'll go up to say 60 gray easily. I can go for there as a different volume, but don't take continuously. That is why skip lesion is there.
Yes, sir. Thank you, sir. Sir, in the case of a stent that is present, should we take
case
into
of-
account
In case of
esophageal stent that has been kept? While contouring, is there anything particular to deal with, sir?
no, they can tolerate any dose of radiation stent. So you don't have to. Like in pacemaker is there, you have to contour and give less dose to that, but the stent does not require.
Yes, sir. I think that's it for the question session, sir. Thanks a lot, sir, for your
Thank
patience.
you.
And
Thank you to talk to you and your team. A really pleasure. I think question from other group, nobody is asking.
yes, sir.
So-
Whatever they've asked, I've asked you,
Oh,
sir.
you have,
I've
okay.
compiled and asked.
Great. Thank you so much. Okay.
Thank you, sir.
Have a good day.
Yeah, yes, sir. Thanks for the crystal clear presentation, sir, and clearing all of our doubts patiently. And I would like to thank Dr. Pooja ma'am and our JIPMER team for organizing this session and giving me the opportunity to host a session with sir, my past teacher. Thank you, sir. I think in yeah. Thank you,
Thank
sir.
you.
We'll
Thank
end
you.
the session. Yeah.